Okay. Good afternoon, everyone. Today I am going to talk about recent therapies in multiple myeloma. It's a very short presentation which I have made, and most of us are practicing in our most of the things which we are doing in our day-to-day clinical practice. I'm going to cover it in diagnostic criteria of multiple myeloma, evaluation of myeloma, newly diagnosed new patient, risk stratification of myeloma, and commonly used recent treatment regimens in myeloma. As all of us know, multiple myeloma is cytogenetically very heterogeneous clonal plasma cell proliferative disorder. It commonly happens more than 90% of the patient are more than 60 years of age. They are elder than 60 years of age. Myeloma always, most of the time, it progresses from the monoclonal gammopathy of unknown significance. It accounts for 1% of all the malignancies, and it's a second common most malignancy in hematological amongst the hematological malignancies. So there is a particular diagnostic criteria to define a case of multiple myeloma. International Myeloma Working Group has put forward diagnostic criteria. When a patient presents with the signs and symptoms which are suggestive of multiple myeloma, diagnostic criteria used are clonal bone marrow plasma cells more than 10%, or proven bony or extramedullary plasmacytoma with one or more of myeloma defining events. So what are those myeloma defining events are? As all of us know, CRAP criteria is one of the myeloma defining event. It can be hypercalcemia, renal insufficiency, or anemia, or any bone lesion. Clonal bone marrow plasma cell more than 60%, involved and uninvolved free light chain ratio greater than 100. Here you have to remember that involved chain should be more than 100 milligram per deciliter, milligram per liter. Or one or more focal lesions on the MRI studies, the focal lesions should be at least 5 millimeter in size. Or a solitary plasmacytoma with more than 10% plasma cells on the bone marrow also can be defined as multiple myeloma. Basically, this particular table summarizes all the diagnostic criteria and the differences between monoclonal gammopathy, smoldering multiple myeloma, and active multiple myeloma. What basic evaluation we should have at the time of diagnosis, diagnosing the new case of multiple myeloma. When I joined as a student in hematology, multiple myeloma used to be one of the expensive workup, to do for any patient. So now it has a base. We should always have a following blood laboratory workup, like complete blood count, liver function, renal function, along with that electrolytes. And we should have a clonality assays like serum protein electrophoresis, free light chain, immunofixation electrophoresis, as well as we should see whether a renal system is involved by 24-hour urine protein. Then to fulfill the diagnostic criteria, we should do the bone marrow smear and bone marrow trephine biopsy. And add-on test would be fluorescent in situ hybridization to prognosticate the myeloma, karyotype to see whether any other genetic abnormalities are there. Nowadays, role of NGS also is being defined in multiple myeloma. PET CT also is used, is very commonly used in clinical practice nowadays to find out a bony disease, and MRI in selected cases. How the myeloma is risk stratified? Traditionally, originally there was international staging system. Later on, it was revised and called as a revised international staging system. Original international staging system as a original diagnostic criteria had only serum albumin and beta-2 microglobulin, but revised international staging system, they included LDH and cytogenetic abnormalities. As all of us know, stage 1 has serum albumin which is more than 3.5, and serum beta 2 microglobulin less than 3.5 with no other genetic abnormality and normal serum LDH. Stage 3 has beta 2 microglobulin which is more than 5.5 and high risk cytogenetic abnormalities like translocation 414, translocation 1416 and deletion 17p. They are called as high risk multiple myelomas. Nowadays, very commonly used staging system is M-SMART, that is a Mayo stratification for myeloma in myeloma. It divides myeloma into standard risk and high risk. Standard risks are all trisomic myelomas, translocation 1114 and translocation 614, whereas high risk myelomas are translocation 414, 1416, 1420, deletion 17p and gain of 1q. Standard risk myeloma are very common and they constitute around 75% of the cases in clinical practice, and high risk myeloma, they constitute about 25% of the total cases. So after we start a treatment for the patients with multiple myeloma, a response assessment is done with the help of criteria, like we categorize the treatment response in various categories. Like we call it as a complete response when we have a previously positive clonality marker, say positive serum electrophoresis or immunofixation electrophoresis. Those positive things should become totally negative on the serum and urine as well. There should be a complete resolution of plasmacytoma, and usually we don't do the bone marrow examination unless patient is planned for a stem cell transplant. So bone marrow clonal plasma cells should be less than 5%. Stringent CR is we should fulfill all the criteria of CR, and we should have a MRD negativity documented either by immunohistochemistry or fluorescent in situ hybridization. But in our clinical practice, we diagnose stringent CR with the help of MRD, which we do by using flow cytometry. Very good partial response is whatever parameters we had a baseline positive, they should reduce more than 90%. It's called as very good partial response, and partial response is positive parameters at baseline should reduce more than 50% but less than 90%. These are commonly used response assessment criteria. This particular cartoon shows evolution of myeloma therapy. Though it is uncurable, myeloma therapy has evolved a lot in last few years. Few of us must be working in the field of myeloma from last 10 years. So for them, myeloma outcome has increased from almost 40% now up to reaching up to 10%. From the time I joined hematology, I see it's just peaked there is a good improvement by 5%, and a lot of new drug regimens have come into the practice. This particular picture shows evolution of therapy in multiple myeloma. The proteasome inhibitors were introduced in 2003, and then immunomodulatory drugs like lenalidomide, they were in clinical use from 2005. Till now, directed therapies like monoclonal antibodies like daratumumab and elotuzumab are being commonly used in a clinical practice. People now are moving to the next level of treatment like bispecific antibodies or CAR T-cell therapy in multiple myeloma. So in clinical practice, first line therapy for transplant eligible patient, this particular flow chart is it gives a very clear guideline to how to treat a multiple myeloma. When we have a newly diagnosed patient who is a transplant eligible, by transplant eligibility means his ECOG performance status is less than 2, and renal function is affected but can be there are no other organ abnormalities. According to this particular flow chart, myeloma is frontline therapy. Patients are restratified into standard risk and high risk. For standard risk criteria, some researchers propose chemotherapy using VRD regimen or commonly used other regimens which are commonly used in case of multiple myeloma are VCD and VTD. VCD and VTD are used when there is a renal failure. VRD is used if there is no renal failure. Initial induction therapy of 3 to 4 cycles followed by early stem cell transplant and that is followed by lenalidomide maintenance. This is a standard practice currently being used. For high risk multiple myeloma, we use a VRD regimen followed by early stem cell transplant and bortezomib based maintenance. Frontline therapy. What is the difference between this diagram and this slide is some authors recommend early stem cell transplant to all the patients of early all transplant eligible standard risk and high risk category. So what are the uses of stem cell transplant in newly diagnosed multiple myeloma? It yields best depth and durability of response. It shortens the duration of multi-drug chemotherapy. It reduces the financial burden to the patient, and it is very efficacious and it confers the complete remission in almost 1/3 of the transplant recipient with median progression-free survival of around 18 to 27 months. Even if we don't give a maintenance therapy followed by stem cell transplant. This particular table shows a role of stem cell transplant versus only chemotherapy, and the role of stem cell transplant was clearly defined in multiple trials, where stem cell transplant gives a more progression-free survival, like up to 27 months. And versus 18 months when we treat the patient with only chemotherapy. Consolidation regimen. Consolidation is advocated by some researchers for the patient who achieved complete, who achieved VGPR or less than that in after 4 to 6 months of induction regimen. And consolidation therapy is always followed by maintenance therapy, minimum for 2 years or till we have evidence of disease progression. For standard risk myeloma, commonly used drug for maintenance is lenalidomide, and for high risk myeloma, commonly used drug is bortezomib. This particular table shows a result of induction and consolidation therapies in autologous stem cell transplant eligible patient. And the role of consolidation therapy is also a commonly it has shown good result by adding a consolidation therapy post stem cell transplant, but none of us are using consolidation therapy in clinical practice post stem cell transplant. Post stem cell transplant, we are directly heading to the maintenance. Treatment of transplant non-eligible myeloma, those are also divided into standard risk and high risk. For standard risk transplant non-eligible myelomas, we should plan a chemotherapy, and that is based on patient's financial state, socioeconomic status. Either it can be a Cyborg regimen or a VRD regimen. It should be given for 8 to 12 cycles followed by lenalidomide maintenance. In elderly patients where performance status is not good, where some authors are recommending daratumumab and lenalidomide with dexamethasone until disease progression. In high risk myeloma cases, VRD 8 to 12 cycles or Cyborg 8 to 12 cycles followed by bortezomib maintenance is currently recommended therapy. This particular table shows transplant various induction regimens in transplant non-eligible patient and their outcome. Commonly used in our practice is VRD again and or pomalidomide or carfilzomib, pomalidomide and dexamethasone, and it has VRD has a response rate, overall response rate of almost 90%, and amongst those almost 74% people have achieved complete remission. Commonly used treatment regimens in relapsed myeloma. Early relapses are those who have early relapses with patients who are treated with prior 1 to 3 lines of therapy. In those who are not refractory to lenalidomide, triplet regimens like daratumumab, lenalidomide and dexamethasone, or carfilzomib, lenalidomide and dexamethasone are commonly used, or doublet regimens like RD and KD are commonly used. This should be followed by autologous stem cell transplant if it is not done in the in the first line as a first line therapy, or previously done transplant where patient has at least a minimum disease free interval of 36 months. Relapsed multiple myeloma. This particular table shows various randomized control trials for first generation regimens for relapsed multiple myeloma. So again here carfilzomib, lenalidomide and dexamethasone has very good outcomes with overall response rates of around almost 87%, and daratumumab, bortezomib and dexamethasone with response rate of 85%. This particular table shows lenalidomide free regimens where patient had received previously lenalidomide. Commonly used in our practice is pomalidomide, bortezomib and dexamethasone with excellent response of around 82%, and it is a cost-effective therapy in to treat relapsed patients. This particular slide shows new therapeutics available in multiple myeloma, like BCL2 inhibitors are under trial like Venetoclax, newer drugs like selinexor, or targeted therapies like iberdomide and bispecific T-cell and T-cell engagers. Cell-based therapies like CAR T-cell and CAR NK cells are under investigation. Commonly used newer therapeutic agent in our clinical practice is daratumumab. It can be used either as a single agent or can be combination of doublet or triplet, and it has shown excellent response. It's available in Indian market, but at a lot of expenses. This particular table shows newer drugs which are available today as part of clinical trial in various Western countries. And they are mostly bispecific targeted therapies like bispecific T-cell engagers and other targeted therapies. With this, I am concluding the small presentation for commonly used treatment in multiple myelomas.
Thank you, Dr. Bala. That was a nice lecture on myeloma and where it is. And so there's a lot of changes in myeloma compared to what we were around 10-15 years back. The number of drugs that are available, the number of options that are available have really multiplied. And the good thing is we having these centers, these drugs available in India, which are what really our patients need. The latest thing, of course, after all of this is the CAR T revolution. And again, we have been hearing about it for the past 2-3 years. And the next 2-3 years, we are going to hear even more about it. CAR T cells are basically engineered T cells. They are not a routine T cell. We manufacture it in such a way that that T cell can go and kill the cancer cells. It's useful in myeloma, leukemia, and the good news in India, the phase 1 study in Tata Memorial Hospital just concluded a few months back, and they're starting phase 2 trials and phase 3 trials in it. We anticipate that next 3 years, we are going to get commercially available CAR T cells across India. And with our population and the number of patients we have, I think it's just going to be a matter of time when everything, the floodgates open and we get a lot of such CAR T cells. So to get a jump ahead on that, Dr. Sikander is here with us. We have been spending time with Dr. Sikander Ailawadhi since morning. He's a Delhi boy, if I can put it that way. He's trained in the US. He did his residency from UCLA and then was working with Mayo for the last 8 years. And now he's head of the clinical cancer international relations for Mayo, and he works at Jacksonville, Florida. He's specializing in myeloma and has done probably so many CAR T cells that he can tell us the nuts and bolts of it. So we requested him to just share with us his experiences on how CAR T cells are done and what are the nuts and bolts and practical aspects of what we can expect while treating CAR T cell therapies.
Absolutely.
Dr. Sikander, over to you.
Thanks a lot, Dr. Vamshi. I can tell you that the amount of information I have over here is probably way more than we'll have time to cover, so I'll cover some of those things. But as Dr. Vamshi mentioned, I'm Sikander Ailawadhi. I hope it's not taken against me that I'm from Delhi originally, but I've been in the US for about 20 years or so now. And I am a hematologist-oncologist from Mayo and Mayo Clinic in Florida, and focus mostly on myeloma, cell therapy, clinical trials, inpatient, outpatient, and outcomes-based research. So we'll talk about CAR T cell therapy today. And as I mentioned, that I'll probably be skipping over some of the portions just to kind of focus on the basics, but I'm hoping that we can talk about the process of CAR T cell therapy, manufacturing, what are the current indications where it's approved as an FDA-approved option. We'll talk a little bit about toxicity, side effects, and also highlight some of the ongoing research. So as Balasab nicely showed the progression of myeloma treatments, this is somehow looking, this schematic is looking more so at the CAR T cell therapy options. And while the concept started more so in '92, now we have even beyond this more options. This schematic is only taking us to the first initial approvals of CAR T cell therapy in the US, which was initially for pediatric ALL and non-Hodgkin lymphoma, relapsed non-Hodgkin lymphoma. And since then, now we have had it in ALL up to 25 years age. We've also had it in follicular lymphoma and transformed lymphoma and multiple myeloma. And within these specific areas, the CAR T cell therapy is getting approved earlier and earlier lines of therapy. We are expecting that in lymphomas, it may actually be approved in the near future for second line therapy. And we are doing clinical trials in newly diagnosed patients also, including high-risk myeloma. So CAR, or chimeric antigen receptor, is an artificial antigen receptor that mediates the T cell engagement and antibody target recognition for the cancer cell. There is a binding between the CAR, which is the chimeric antigen receptor, and its antigen on the tumor cell, and that binding triggers the signal transduction cascade and downstream killing of the cancer. This process will activate some T cells, but obviously those CARs are on the T cells that are from the patient. I should point out all the approved ones currently are autologous. Down the road, we are expecting allogeneic off-the-shelf CAR Ts also. We have them in clinical trials, but none of them are approved yet. And effectively, this creates a graft versus tumor effect without having a graft versus host disease. Now, just talking about the process, because there have been some questions about it during the day today, so I wanted to point out that when a patient has their process through CAR T, it involves a ton of coordination. Way more coordination than we need for stem cell transplant. There is a referring physician or ourselves, because we are a CAR T referral center, so we have patients who are coming in either seeking us themselves or patients who are being referred in from community oncologists for CAR T cell therapy. So a patient is identified either internally or from outside. They are referred to a CAR T center. So within our practice, we have a group of us who do CAR T cell therapy and bone marrow transplant and cell therapy. So if, let's say, hypothetically, there's a myeloma patient who's under the treatment of one of our physicians who does not do transplant and CAR T, they will refer the patient to one of us, so let's say me, or somebody in the community will send the patient over. We do have to, first of all, assess their eligibility for clinical and financial. So every patient runs through a pre-approval for insurance. So, for example, this morning I was calling a patient back in the US because he wants his CAR T cell treatment tomorrow. But what I was trying to impress upon him was that it is FDA approved for patients with at least 4 prior lines of therapy for myeloma. He's only had 2 lines of therapy. So even if I want to give him CAR T, I can't because it won't be approved by the insurance. And the price tag on the CAR T itself is about $500,000, about $500,000 just for the CAR T that is pre and post. So we do need insurance approval. So we start there. Patient is pre-approved. After that, the patient has clinical eligibility assessed by us. So we will see them in clinic. We will assess if the patient meets all the criteria. Balasab mentioned about the ECOG performance status. We will talk about any other uncontrolled illnesses, etc. I can tell you that maybe the workflow is a little bit different in myeloma as compared to our lymphoma and leukemia clinics, because in lymphoma, leukemia patient is coming only for CAR T. In myeloma, what at least I've set up in Florida, it's 4 of us who focus on myeloma, is that every patient who wants to get a CAR T, they first start with us. We start them even without the financial approval, etc., because if that patient is not clinically eligible for a CAR T yet, I can offer them other clinical trials, other treatments, etc. We have about maybe 12, 14 clinical trials in myeloma running. So why bother just bringing the patient for CAR T? But I can tell you the practical aspect is financial approval, then clinical assessment. And once we say that the patient is clinically assessed, right now the biggest deal is to try and secure a CAR T manufacturing slot for the patient. I'll go through some of the slides, and like I said, I'm clear now that I won't be focusing on a lot of the clinical trial data. I think it's about the practical aspects that's more important. So at this point, because of the limitation on CAR T cell manufacturing slots, because these manufacturings are happening with the pharma companies. So if a CAR T cell is available through BMS or Novartis or Kite or Janssen or whoever, we have to get a slot from that company to manufacture the cells. The way the companies are set up right now, they will get us a slot for when we are allowed to collect the cells. Once we get a slot, right now we're getting anywhere from 2 to 3 slots only a month. Once I have a slot, we will discuss the patient and we'll figure out who's our patient who fits that the best. We'll constantly readdress our wait list and our patient list. We have a wait list of anywhere from 40 to 50 patients at any given time. But who may be eligible for the CAR T in July and August and September, we have to constantly discuss. We have a once-a-week meeting where we do that. Once a patient is identified, a date for collection is identified, then we start calculating backwards. Because for about 2 weeks prior to collection, 1 to 2 weeks prior to collection, we want all their treatment to stop so the patient is not dealing with any side effects from the treatment when they're going through collection. CAR T cell therapy does not have a lot of standard guidelines of what kind of testing is needed. So majority of us are doing exactly the same kind of testing that is needed for stem cell transplant. But additionally, every patient gets a baseline neurological assessment. We should be doing it ourselves, but we get neurology to do it. They can do a better job at examining and neuropathy testing and stuff. Every patient ends up getting a baseline brain MRI, and I'll tell you why that is important. Everybody gets echocardiogram, lung function tests, etc., all infectious workup. And that is done in typically 1 to 2 weeks prior to apheresis or T cell collection. Then once this workup has been complete, that patient has a visit with a clinician to go over the workup, make sure everything is fine. And then the patient is approved for T cell collection, clinically approved. Remember, financially, they are already approved. That is when the apheresis happens, the T cell collection happens. Now, as against stem cell collection, autologous, which can take 2, 3, 4 days, T cell collection is a 1-day job. The patient comes in the morning, gets a central line placed, an apheresis catheter, then they go to the apheresis unit, They're connected to the apheresis machine, sit there for about 2-3 hours. T cells are manufactured, put into a bag. Bag is sealed, line is taken out, patient goes home. That's when the clock starts, because now this T cell collection is going to be sent to the company for manufacturing. I had a few questions today about, well, can't you just manufacture that at Mayo? Yeah, we do have a GMP facility and we do manufacture cars, but the ones that we would manufacture are all research. Because remember, nobody can get up and say, I want to prepare my own cyclophosphamide and give to the patient. You have to have an approved drug that you can take and give. Similarly, these CAR T cells, although they are like cell therapy, like transplant is the patient product, but it's a drug. So then when we send those T cells, which is that central bar, that has gone to the company. Right now, the turnaround time can be anywhere from 2 weeks to 8 weeks, depending on the product. Some of the lymphoma products come back in 2 to 3 weeks. One of the myeloma products comes back in about 4 weeks. The other myeloma product, so the first one, which is Affordability, which is Islet Cell from BMS, average turnaround is 4 weeks. The second one, which was approved second, which is Carvykti, Janssen, or Cilta-cel, that takes anywhere from 6 to 8 weeks to manufacture and bring back. So once we've collected the T cells and sent them back, now it's again back to us clinicians to keep the disease quiet for those 4 to 6 weeks. And before we give the T cells back to the patient, the manufactured T cells, the patient is typically kept free of any treatment for about a week or so, week to 10 days. We want to give them that much gap to condition the body to get, and I'll come to that in a second. So T cells are sent, disease is kept quiet. Then the patient gets what's called conditioning chemotherapy. That conditioning is different in transplant versus CAR T. Transplant, they get something that is myeloablative. Chemotherapy, we give it, the bone marrow is gone. Unless we give the stem cells, bone marrow is dead. The chemotherapy in CAR T is different. It is lymphodepleting. It's not myeloablative. So the leftover T lymphocytes in the circulation in the bone marrow, they are the ones to be killed. Typically, the patients get 3 days of fludarabine and cyclophosphamide. So it's 3 days of flu-cy that they get, which is all given outpatient. So they get 3 days of conditioning. Then the next day is generally off. The patient is then admitted to the hospital. So it's -3, -5, -4, -3 is the chemo. -2 is off. -1 is when the patient gets admitted to the hospital just to fluids, labs, making sure everything is fine. And then the next day they get their cells back. I'm sorry, I've been on this slide long enough, it seems. But that's when the T cell infusion happens, and then the count up starts. Because after the T cell infusion, it takes anywhere, the patient typically stays in the hospital for 10 to 14 days. During that, all kinds of side effects happen, which we'll talk about. And then the patient gets discharged, but they still stay around within 30 minutes for another 2 weeks. Once the patient hits the day 30 mark, that's when we let them go back from wherever they came. And that's when they start once a month follow-up with us, or less frequent. So that is basically the CAR T cell journey for a patient in a nutshell. And I know that has taken majority of the time right now. This slide is talking more about the CAR T cell production part of it. So when leukapheresis was done, leukocytes were taken, T lymphocytes were taken. That is when we will send them to the company. The company will do T cell enrichment. Then they will do T cell activation and expansion. Then they will incubate the T cells with a viral vector. That viral vector will introduce whatever we want to introduce, whatever is that target that the CARs. I mean, this is as close to sci-fi in medicine as it can get. We're taking cells from the patient, we are expanding them in the lab, we are incubating with them with a lentiviral vector typically. That virus is bringing that antigen that is needed to be connected with the cancer cell, because myeloma has BCMA. I'm taking the example of myeloma because Balasab talked about that. And during that incubation, that vector is integrated, the genetic material is integrated into the lymphocyte DNA, and that's when these CARs, or the antigen receptor T cells, they are expanded, put back into a bag, and sent back to the site. So we receive a bag of T cells, and then when we are ready to give it to the patient, we thaw that cryopreserved and we give it to the patient. We have an internal policy that we will not start the lymphodepleting chemo before we have the CARs in hand, because there can be manufacturing failures. Now, because this is an FDA-approved drug, if the manufacturing fails, if there is less than 80% viability of those cells, it cannot be released to the patients. All of that process went waste. If it is below 70%, there is absolutely no way it will be released. If it is between 70 and 80% viability, then it can be given to the patient under an expanded access process. And every CAR-T process has an expanded access program. And once the patient gets the CAR-T, they automatically get into a 15-year follow-up. Of course, so far, 15-year follow-ups have not panned out, except acute leukemia is going several years. But that is a requirement by the FDA to monitor for any long-term effects. I'm not going to talk much about lymphodepleting therapy. And actually, if it's okay, I'm going to skip over some of these early approvals. I'm not going to take you through clinical trials, but what I'm interested in is coming to CAR-T versus transplant, because that is an important question that is coming up, and now trials have started looking at that. Most of the data is coming from transplant, where there are from lymphoma, where there are 3 CAR products FDA approved. There are 3 products. One is Yescarta, one is Kymriah, one is Breyanzi. And all of them are running head-to-head clinical trials with transplant, suggesting wherever CAR-T may be more beneficial. And in fact, in one study, some real-world patients who have undergone transplant have been taken up, matched with CAR-T patients, and trying to show if the outcomes are better, because that's kind of a faster, dirtier way of doing an analysis, but at least gives us some idea. This is again looking at these randomized clinical trials, which are ongoing, but you can see, for example, this first one with Axicell, one of the FDA-approved agents. We're looking at median progression-free survival in that population, second-line therapy, 14.7 months versus 3.7 months with transplant. So there is no reason for us to think that in some places, CAR-T will probably replace transplant. We've already started thinking of that in myeloma, but the lymphoma is a little bit further ahead from that standpoint. And of course, then maybe what I'll do is, instead of going through the whole data, I'll take myeloma as the case study, because again, my own area, that's what I've spent most time in. Balasab talked about antibody drug conjugates. The one FDA approved is belantamab in the US. CAR-T cell therapy and bispecific antibodies. Everything has its own pros and cons. But the kind of philosophy that I use in today's day and age is, I would like every single myeloma patient to get access to one BCMA-directed therapy, ideally. The most preferable for a young, robust, healthy patient would be CAR-T, because it's a one and done, and then we can get anywhere from 12 to 24 months of progression-free survival. The second, which I have participated in a lot of clinical trials for bispecific antibodies, in addition to CAR-T, bispecific antibodies, these are so effective that sometimes within the first 2 weeks, the disease melts away, and the patients achieve MRD negativity for 2 years plus. But the bottom line is, not everybody is able to get that. So if they are not CAR-T eligible, they can't get onto a clinical trial. We do have an antibody drug conjugate that is available. So we try that the patient is able to get that antibody drug conjugate against BCMA, which is B cell maturation antigen, which is the common target for all of this we're talking about. And we would like the patients to get that access. CAR-T in myeloma, as I mentioned, BCMA or B cell maturation antigen is the target. BCMA is expressed in most patients with myeloma, and it is not expressed in non-hematopoietic cells, so relatively specific. And then it's an ideal target. And this particular case is actually one of my cases, which with tons of PET scan, positive disease free, and then the second is a post CAR T PET scan about literally 2 months later. There are 2 that are currently FDA approved. I don't think we'll go over a lot of this data because we won't compare them. But I think what I want to focus on is how are we dealing with CAR T and where is the field moving? Because I do want more time for an open discussion to go over stuff. So I think the things that we are dealing with practically day in and day out are, one is access to CAR T. Not everybody has access. There are several centers in the US, but frankly, there is an analysis out of CIBMTR, which is the Central Bone Marrow Transplant Registry in the US, that out of those myeloma patients who are considered stem cell transplant eligible, only 20% are referred to a transplant center and then go on to getting a transplant. So when we have that kind of a disparity with transplant, what's going to happen with CAR T, where there are less manufacturing slots, less centers, more cost, more fear, lack of awareness and education, etc., etc. Another thing we are dealing with is the same patient is going from center to center to center and putting their names on the lists, clogging up the lists and making decisions very difficult. And what we have done is, at least internally, we have said that, okay, for certain payer mix, because Medicare which is above 65, government insurance is the most common, we've said that we will only offer that to patients who do not have another closer center to them. So we've fixed a 100-mile radius to say that we will only offer it to patients within the 100-mile radius. We'll tell them to go to another center otherwise. Of course, commercial patients are different. Toxicity management is important, understanding and managing the toxicities. As I said, manufacturing slots are very difficult. As it is, forget about even the manufacturing slots. We are running out of apheresis slots. We were already very tied up with apheresis for our autos and allos. And on top of that, now we are also adding T-cell apheresis. Of course, it's 1 day as compared to more days. We don't have that much capacity. So building capacity is becoming an issue. Affordability is a very big problem, although insurance covers it. But as I mentioned, the cost is just ridiculous. $500,000 for just the drug part of it. Of course, nobody's paying out of pocket. Majority of the patients are not paying out of pocket. There are ones who will come and say, I want to pay cash. We are going towards non-BCMA targeted therapies because we cannot keep using the same target again and again. So a patient can only ideally get one CAR against BCMA. Well, they're going to fail that. What are they going to go next? So there are CD38 CARs, there are CARs against Kappa, et cetera, others are coming by. And then we're using CAR Ts in earlier line of therapy. We have a clinical trial with frontline CAR T cell therapy also for high-risk myeloma. So I'll not talk about the other agents. We are talking about CAR NK therapy, which we are working on developing, and I am going to probably go directly to the adverse event management, which I think is a very important part because CAR T cell therapy brings with it a novel situation of side effect profile management. These are side effect profiles that we haven't had before or handled before. The 2 main side effects, actually there are a few more, but the 2 main that we have to constantly work on and worry about and take care of, one is cytokine release syndrome. You can imagine that we're giving a very targeted increased volume of T cells, activated T cells. They are going in, they are causing a reaction with that BCMA target, and that massive cytokine release is happening. In earlier treatments, when CAR T had just come about, patients used to die with cytokine release syndrome. Now I don't think they do. I think we've become much better at managing it. But for example, this is an IL-2 mediated phenomenon, IL-6 mediated phenomenon. The antidote for that is tocilizumab. So for example, it is right now a requirement that for each CAR T cell therapy, we have to have 2 doses of tocilizumab available on hand. Otherwise, I can't take a patient through CAR T. I have to be able to check a box through pharmacy saying we have 2 doses stored and ready to go for this patient. Cytokine release syndrome could be as simple as a low-grade unexplained fever. It could be as bad as patient completely going into a circulatory shock and requiring multiple pressors and ending up in the ICU. Luckily, as I said, we are not in a situation that the latter happens that much. So we will give standard management for that early fever, but when that fever becomes persistent, unexplained, or when that fever is accompanied with hypotension, we will immediately start with tocilizumab. And it's very rapidly reversible. Infrequently, patients need 2 doses of tocilizumab. With COVID, one of the issues was toci shortage, because toci was used for COVID. So we've used anakinra, we have done other things, but I think it didn't really make much of that was not much of an issue. We were able to handle it. As I mentioned, the treatment of CRS, grade 1 could be just supportive, grade 2 could be IV fluids or for hypotension, oxygen, but very frequently we just start with toci right away, and sometimes the patients need a second dose of toci. Response to tocilizumab is extremely rapid, and within hours the patients are completely fine. If they are refractory, we can use anakinra, as I mentioned, which is an IL-1 inhibitor, siltuximab, JAK inhibition. Those are options, but we have typically not needed them. The second major side effect is ICANS, or immune cell related neurotoxicity. And this immune effector cell associated neurotoxicity syndrome, in the very beginning when CAR T came, every institution had a different criteria for grading and managing. Now almost everybody uses similar criteria. This is the second most common adverse event, but is the more dreaded one, because it could be as simple as a headache, and it could be as bad as the patient ending up in the ICU with encephalopathy kind of things, completely aphasic, blind, whatever, and then we have to treat it, and typically it's reversible. But the other issue with neurotoxicity is that the treatment for this is steroids. And you can imagine in a patient who we have given T lymphocytes to, we want to avoid steroids if we can to not cause lymphodepletion and not cause an inefficacy of those T cells. But still, if a patient has neurotoxicity, we'll use steroids. And it is quite rapidly reversible with steroids. One of my recent patients that was a lymphoma patient. I was on service in the cell therapy unit, and he went from being completely aphasic, requiring 2 pressors, to, because I guess overnight was seen by an overnight person who was not well versed, or they missed the timeline for the first toci, to literally 24, 36 hours later being off all pressors, sitting in the ICU, talking and eating food. That's how rapid the reversibility is. And with steroids and toci, that can happen. Of course, we don't give toci for neuro. Toci is only for CRS. So HLH, or hemophagocytic lymphohistiocytosis, can happen, extremely rare but very, very concerning. Another thing that we are concerned about, we're concerned about infections. We don't really, they typically don't happen. But another thing that we're concerned about is long-term cytopenias. That is where what we've started doing now is, traditionally for myeloma, again, going back to myeloma, we collect stem cells for 2 transplants. We presented data last year at American Society of Hematology that in about 97% of the cases, we never do the second transplant. And that causes millions of dollars of additional cost to the system, which the patient doesn't pay, but the system pays to just store those cells. But now we have started using those cells more for those prolonged cytopenias after CAR T. We have started giving them stem cell boosts just to recover their marrow better. And it started working, not just Mayo, that's happening across the country, across the world, that the leftover stem cells from myeloma auto transplant are being used to give a stem cell boost after prolonged cytopenias from CAR T. It's also extremely important to try and predict this toxicity, because obviously the toxicity, there are acute phase reactants based on CRP, ferritin, etc., where we are able to mention, or we are able to predict who is at a higher risk of certain toxicities. But bottom line is, from CAR T cell therapy, we want it more affordable, which it is not right now. We want a variety of different targets. We want it to be safe. We want persistence of those CARs, because frankly, if the disease starts progressing after CAR T, which frankly outside of acute leukemia, almost everybody progresses. Lymphomas have had some subset of patients who have had long-term responses. And the cause could be either that antigen is lost, so that plasma cell which had the BCMA target, that BCMA is gone, plasma cell has started growing. That is one possibility. But more likely that the research is suggesting is these T cells get exhausted. These T cells over time just get exhausted and the disease starts growing. So there are studies looking at how to make the T cells persist and how to also, for example, engage or recruit them. For example, some of the immunomodulators like lenalidomide, pomalidomide, iberdomide, they are being tried as maintenance strategies for CAR T. And then how to proliferate them. So again, in summary, it continues to be very promising. It is currently indicated for relapsed diffuse large B-cell, B-cell ALL, mantle cell, follicular, and myeloma. AML is still in very early stages. There is an effort to improve efficacy and limit the toxicity. And then we do have a lot of clinical trials already ongoing in solid tumors. For example, we have breast CARs, we have pancreatic CARs, we have hepatic CARs, and we have GBM focused CARs in clinical trials and sarcoma. So within that, our program involves, we do offer all of the FDA approved CAR T cells in our clinics at all 3 sites. We have a lot of clinical trials, including myeloma, non-Hodgkin, allogeneic off-the-shelf CAR Ts for CLL, for sarcoma, and then we are anticipating opening more. Sorry. So I did stop on time and I skipped a lot of the information, but this presentation is available here, so happy to share it down the road. Thanks.
Thank you, Dr. Sikander, for a nice presentation. Next, we have a small panel discussion about management of non-Hodgkin's lymphoma. For that, I would like to invite Dr. Ganesh Jaishetwar as a moderator, along with panelist Dr. Pawan, Hemato-Oncologist and stem cell transplant physician from Indo-American, Baswatarakam Indo-American Cancer Institute. Unfortunately, 2 of our panelists hasn't come. One panelist is busy with family emergency. I would like to invite Dr. Arif, medical oncologist, AIG Hospital.
my colleagues at AIG for this wonderful academic opportunity. I'm so sorry I much behind time. Yeah. Yes. So, apologies, sir. This is first time I am wearing this science gadgets, and we are used to conventional presentations. And thanks to COVID pandemic, little techno savvy, but not up to the mark. So,
Before he starts, the humble, so Dr. Ganesh is a senior hematologist in the town. So he's more like our mentor here.
okay. Okay. But, yes. So, the panel discussion after the, the authoritative talk, I missed it, sorry. Part of it I was on the go. So, thank you so much, all the team AIG for this opportunity, and I'm sure Dr. Arif is here, Dr. Stalin, we missed, Dr. Pawan, senior hematologist, hemato-oncologist, and a transplanter from Basotarakam. Dr. Karuna is not there, Dr. Vikram, and Dr. Ashok. So when we were discussing about this panel discussion, a lot of my eminent panelists asked, sir, we don't have any experience, Dr. Ganesh, we don't have any experience of CAR-T. What is the point of discussing? I said, we have a legendary speaker, so let us put before our perspective on what we think about CAR-T cell. And just like the cartoon, the flight is easy to take off, but then in the middle of the storm, we should know what we are doing and we should know what not to do. So, it's kind of CAR-T is these kind of immunotherapies are going to be at everybody's practice in a year or so. Even in India, there are many, positive, encouraging trials, phase 2, phase 3 are going on, and very soon I hope these kind of immunotherapy platforms will be accessible to our patients in our city, Hyderabad. So this is in regard to that. And this is a real life case, a 29-year lady, which I treated long back, Dlvcl stage 3B, RIPI3 poor risk group. And this was her picture at presentation, this was her pathology. And to add further, I will skip the pathology part, but then she turned out to be c-MYC BCL2 positive, c-MYC on fish. So this was a clear-cut case of, can we remove that picture please? So how to treat this such case, double-hit lymphoma in a very, very young, healthy, fit girl. So Dr. Pawan, I'm sorry to take you back to the diagnostic profile, but this is a very common test nowadays. I'm sure all of us do molecular test fish, but does any of us is doing NGS for lymphoma, any of the institutes in India?
We as a institution, we only do fish, BCL2, BCL6 and c-MYC. So some centers have seen doing NGS, especially only P53 PCR, not the whole panel, only P53. But as an institution, we are only doing a fish panel for 3.
So P53 by IHC or?
No, by PCR.
PCR. Okay. So Dr. Arif?
We recommend IHC, sir, IHC in every patient to rule out some double express or something. And if the patient is willing, then we are doing FISH also. FISH, though it's recent trials have shown that double hit is not managed in a different manner. It need not be, though it needs aggressive treatment, but nothing more than R-CHOP, R-EPOCH and R-CHOP, both are almost same in the treatment. The outcomes remain same even in the double hit. So what is the benefit now of doing extra FISH and just it to be a prognostication as such?
So sir, your practice?
So I think what Dr. Arif you're bringing up is a very important question. Is we deal with these situations very frequently, as in what is the benefit of doing a very futuristic kind of a test if I cannot use it for a clinical decision making?
Yeah.
And we struggle with this on a day-to-day practice. We do IHC for expression and sequencing. At least starts with everybody gets the FISH. But we do get a lot of patients from outside, and NGS may not always be covered under insurance, especially when a patient is Medicare who's 65 years plus. That is a government process just to make sure that those patients are actually asked to sign a form saying that if insurance doesn't pay for it, they will have to bear the cost. That is almost prohibitive. So what I can say is that we are dealing with the same question in ALL MRD initially, with myeloma MRD now, with these kind of molecular testings and diffuse large B cell, etc., etc., etc. But I think the one very important piece that doesn't always get fully utilized is what you mentioned, Dr. Arif, the prognostic value. Because for that 29-year-old patient, if you get the c-MYC and BCL2, and let's say that is the double hit, even if you're going to use the R-EPOCH, you know that the outcome is going to be way poorer. So while we are able to use that term, tell the patient, oh, your 5-year survival or your 7-year survival, frankly, for a 29-year-old, even a 40-year survival may not be enough. So I think, yes, we do it routinely. And I think in addition to may or may not have a therapeutic benefit, I think that prognostic information is extremely important for that 29-year-old to be able to plan their life, to be able to figure out things. So with that in mind, we do it routinely.
So that is a very valid point, sir. Like the last year IHA and so many conferences, this NGS based prognostication, to which coordinates a specific genetic signature, and this was the first paper was, I think 3 groups parallelly were doing this So Dr. Stewart Chapue published in 2018. So can I have the slide, please? So this was based on NGS, the profile of 5 definite subgroups, and the first time probably we have a segregation. So the cell of origin has not impacted neither the therapy nor the prognosis. But yes, this kind of, and as you correctly pointed out, sir, so for example, in a country like ours, NGS is now very easily accessible for though through commercial platforms, and the cost is also compared to the cost of therapy is not very high. And we learned the same lesson from AML, and we are learning from ALL now. You started doing NGS long back, 6-7 years back, and now we are seeing certain correlates which really can help us prognosticate. So probably the field is moving fast in DLBCL also. So over a period of time, this is just the beginning of a, I feel, better prognostic era, which will help us devise, particularly in such young patient who has double hit lymphoma. So just to, such patients who have, we expect them to do poor. So, so after RCHOP 21, there has been nothing significant, discovery for more than almost 2 decades. Anything which has added to the RCHOP backbone has not proved the outcome. So, adding a new drug, new targeted drug, consolidation with maintenance, replacing one component like bortezomib or obinutuzumab has not really helped improving the outcome across the various subgroups. This is better, I think. Sorry for the distance. Now? I'm so sorry, being new to this kind of platforms is a struggle sometimes. So coming to our case, double hit lymphoma, the impact of induction intensity, and there has been enough literature. But yes, young fit patients, we do intensify the upfront regimen, like there are some case series and some not so conclusive, robust data, but yes, for a young patient like this, we'll definitely intensify the upfront regimen. Like we treated her with DIPOC and 6 cycles. She was in remission. You will present from there. So, coming to our case, now many of us enthusiastic transplanters do consolidate such cases, young fit lady, unmarried, with upfront ATO. What is your practice, Dr. She is in complete metabolic response, and she has upfront poor risk profile based on revised IPI. So she has stage 3B disease, she has very high LDH, more than only favorable factor amongst that RIPI was her age. And if you go to age adjusted IPI, again it falls into risk.
Non-GCP subtype DLBCLs starts part RLI plus not CHOP by MD and risk group had a 96% PFS and OS though it was a single arm study. Do you think that this combination of RLA R-CHOP can replace? So for the benefit of many, so RLA R-CHOP has been shown in a single arm studies of 96% survival rates. So do you think this combination in future, though phase 3 is going on, in future can replace the high risk genetics, the poor prognosis associated with the high risk genetic? It can mitigate the difference between the outcome.
So I think that's an excellent question, because as was mentioned, we struggle with this group. Everybody responds, a majority of the patients respond, but nobody stays in that response state. Everybody progresses. And once they progress, controlling is difficult. I think what I would say is to use that data with a grain of salt, exactly like you mentioned, single arm phase 2 study. And I'll take you back to probably the data from MD Anderson for FCR in CLL. Single arm studies, excellent long-term outcomes. But the moment you go into a randomized phase 3 trial, the outcomes look very different. And then down the road, there is slowly and gradually, there was only one subset of patients who had that benefit, and eventually that is lost. So that now in today's day and age, we hardly use chemoimmunotherapy in CLL anymore. So I would probably say that it's important to use that data with that caution, that it's a single arm phase 2. Progression-free survival at a certain time point is reasonable. Overall survival at that time point, it is hard to say whether it came from that regimen or was that group destined to do the same had they received, let's say, as was mentioned, REPOC. So that's where we have struggled in the past, where R-CHOP with Velcade, R2-CHOP with Revlimid, somehow nothing has clicked, nothing has shown that benefit. I still feel it may be our strategy for these kind of patients, not only just in diffuse large B-cell, but even high-risk myeloma, poor-risk ALL, etc. The idea is to use, to have, I'm saying idea as if it will succeed, but the hope is that you debulk with something and then you bring in some strategy to maintain that response. In diffuse large B-cell, maintenance has never been of any benefit. Whether a consolidative therapy with a CAR T cell in that situation, and you have healthy T cells, maybe that will have a role. We didn't touch upon CAR T today, but the more you keep treating the patient, their T cells keep getting beat up. Collecting those beat up T cells and manufacturing them and then giving them back to the patient, they're going to exhaust much faster. Hence the thought of using CAR T sooner, earlier. But I guess I'll go back to our panel over here, just the thought that if we are to modify, do we do those things? Do we not do those things? Any thoughts?
So I think coming to that's a high CR rate has been a good thing, but in a specific case like this, maintaining a PFS, I don't know whether that will help. The RSMART trial, what you have mentioned actually. The question Dr. Ganesh had put forward, can we consolidate these patients upfront with a transplant? There are two answers. Scientifically, there is a data that we have a PFS benefit in most of the patients. But coming back to institutional protocols and all, we have tried, and because of morbidity and mortalities, we are not doing upfront autologous stem cell transplant. I personally will feel as an institution, we are not going ahead with upfront autologous transplantation. Though we have PFS benefit, no OS benefit.
Okay. So what is your practice?
So we also don't use upfront transplant for the same reason that you can show that PFS benefit, but the overall survival benefit always fails. So we typically will treat them, they go into response, we cross our fingers and we start waiting then.
So for this lady also, just put this case. So 6 cycles of ARDA-IPOC, 6 cycles of integrated with intrathecal CNS prophylaxis, and we incorporated 2 cycles of high-dose methotrexate in between, and she achieved complete metabolic response. So we discussed. So for her, as this question is a very eminent, but this was way back in 2017. So because of her age and she happened to belong from a doctor's family, so looking at the risk and benefits, pros and cons of transplant, so they decided to go for afferent autologous stem cell transplant consolidation. Her transplant was with, peri-transplant period was stormy. She has swine flu, but she recovered. And with a disease-free survival of almost close to 1 year, she has a relapse. What next in such cases? So, she is a 29-year fit lady, post 6 cycles of Ardha epoch and Hemato-transplant. What are your options in 2022?
I think way clear. CAR-T, that's what, again, it's to scientifically and availability, practicality. Availability and the best option scientifically, yes, she'll be the best candidate for a CAR-T. High-risk disease, though relapse post autologous stem cell transplantation, probably she should be a candidate for CAR-T. Whatever Zuma 7 second line, we have an option. Scientific availability, practicality in our setup where we don't have an option of CAR-T, probably a second salvage with some platinum-based chemotherapy, and take it for an allo.
So I think it is very precisely clear as per the various guidelines from various societies. So post-auto-transplant relapse is an ideal candidate for CAR-T. So Dr. Arif, since the CAR-T is not available with us, so
what we are aiming at, if we want to cure, then, or it's just palliative. If it is cure, I will try if it's second salvage and go for, as Pawan said, allo, maybe in the second.
So Dr. Dr. Narendra sir, so transplant. But any other non-CAR-T therapeutics, even of course most of it is not available to our patients' disposal, but so what we did, so this is a common discussion across various platforms. So Dlvcl, about 50 to 60% get cured. Can I have the slide deck, please? 10 to 15% are refractory, 20 to 30% relapse. Of those relapse, 50% are transplant eligible. Of these transplant eligible patients, half of them are chemosensitive to go on for subsequent transplant. Then 50% either by age comorbidities are non-transplant eligible, and 45% are non-responder to salvage therapy. So this is an unmet need even in our country. So if you look overall relapse patients or refractory patients, only 30 to 40% of those patients undergoing transplant are cured, and then 60 to 70% who relapse after transplant or who are non-transplant eligible, who are chemorefractory at the time of transplant. This is total 30% of Dlvcl chunk, and this is a real challenge. So there are many novel therapeutics coming up. So whatever is available in India, I put before. So PD-1 inhibitors, our oncology colleagues are using quite extensively. And is there any role of PD-1 inhibitors or Venetoclax, ibrutinib, whatever is available to our disposal?
So checkpoint inhibitors, we have a data in PMBCL, very clear. Sometimes in our own experience, patients, though proving PMBCL is a big headache for us many times, so patients with majorly a mediastinal DLBCL, a gray zone, there we have checked PDL1, that's an antibody we check, and there's a TPS score of more than 20%. We have seen a response with checkpoint inhibitors plus chemotherapy, like we see in our regular solid tumors. And because PMBCL tend to have more than 90% CPS or the prognostic score. And in especially the mediastinal based large B cell lymphomas, there we have noticed the PDL1 antibody, the CPS or TPS score is more than 50%. There the checkpoint, say a single agent checkpoint inhibitor with pembrolizumab or nivolumab, though pembrolizumab has data, we have seen there is a response. Other things.
But before adding checkpoint inhibitors, do you do that?
We do as a percentage, because one of our pathology resident somehow is checking what is the percentage. But we have noticed
in DLBCL, this is not PMBCL.
No, all DLBCL per se. So we only noticed the mediastinal based
PMBCL has, yes.
Or any large B cell lymphoma, the PDL this thing was high, but other days they are 1%, 2%. Where primary refractory we have used, when it's more than 1%, we have just tried, but there is no other option. Second option of using Venetoclax, we have tried in 2 patients. Again, dosing is not we still it didn't work. To be very precise.
So,
No, it-
can I have the slide deck, please?
Yeah.
So, basically, she was BCL2 positive at relapse also, and so out of desperation, this is not on any scientific rationale or based on any of the indications. This was through the family was very willing, young lady, fit. So I tried Dexa, Ibrutinib, Venetoclax, and she achieved almost near total metabolic response after 3 cycles of this. So now, after achieving CR2, again, this is a double hit relapse, post auto transplant relapse. Again, the indications are clear cut. Probably, if the CAR T is available, we'll go for CAR T plus or minus allo transplant to maintain that response. So, what we did, these are the various therapeutics we explained with her. We also gave her the option of going on to a CAR T enrollment anywhere across the places where it is available, but looking at the cost and looking at the logistic requirement, they preferred for haplo. So, this is probably a recent upcoming data, the recent advances in relapse refractory DLBCL. So, for patients who have a first, even in the US, I think still the CAR T approval is only after 2 failed lines or those who relapse post transplant. So the point is, even in most developed center across the globe, the first relapse of DLBCL, which is chemosensitive, the current standard of care is autologous stem cell transplant. And those who relapse post transplant, those who have a chemo-refractory disease to salvage, probably these are the patients to CAR T, and there are non-CAR T novel therapeutic options. I think I put tafasitamab lenalidomide as the only option in my slide deck, because across the literature I found probably that is the only novel therapeutic platform which had shown a plateau in the survival curve for long run. So this is, again, we all know all the long-term follow-up of these classical 3 pivotal CAR T studies shows about 40% of them maintain a long-term disease-free survival. So I found this interesting paper just published a couple of months back by Shadman and Hamadani group. So the auto transplant versus CAR T in patients with DLBCL who are partially responsive to salvage regimens. Of course, this is a retrospective analysis, but this is very, very promising and for us encouraging, because most of us feel the response to salvage chemotherapy is not optimal. That's the end of the road. Still, there is a lot of scope to salvage, significant proportion of those patients. You can see those patients who are in partial remission post salvage chemotherapy. Comparing CAR T versus auto transplant, again, this is a retrospective analysis. It should be taken with a pinch of salt. But auto transplant is not inferior to CAR T even in this subset. So I was surprised. So all that glitters is not gold is very, very true. So coming to the various other non-CAR T, non-transplant, novel therapeutic options, I found this one interesting, L-MIND study design. You can see median PFS of 12 months, median OS at a follow-up of 3 years still not reached, and there the survival curves seems to be plateauing on long run. So this is relatively of importance, might be for our practice. So in our subset of patients, Dr. Pawan and Dr. Arif, tomorrow CAR T is available, accessible to us. Where will you put CAR T immunotherapy, cellular therapy option for patients in relapse as well as refractory DLBCL?
So as a second line, probably the early relapse patients or high risk, so-called high risk IPI or the double hits, triple hits. I think those are the patients who should go ahead with a CAR T therapy as second line upfront. Probably a late relapse or slightly, but or probably young patients, probably an early relapse will go into early second line CAR T. Other patients probably will push it to the third line.
Dr. Arif?
So those are not eligible for transplant, like frail old people who we can't salvage and transplant them. Better to give CAR T cells. It's not so myelosuppressive and myeloablative, and they couldn't tolerate this regimen.
So Dr. Bala, Dr. Vamshi, Dr. Narendra sir, for our lady, 29 years young fit lady, she has double hit lymphoma and at first relapse, will you consider auto transplant or CAR? So because these patients are tend to do poorer on a long-term follow. So looking at the literature, I think even though the indications are not yet approved across the various regulatory authorities, but particularly this kind of subsets, the younger patient who has double hit lymphoma who relapses early, the patients who have a relapsed or refractory Dlvcl who have high RPI at relapse, those who have the high RPI, those who have elderly patients or the patients with such kind of double hit lymphomas, probably CAR-T might fare better compared to taking them to conventional autologous transplant. So the basis of autologous transplant consolidation comes from PARMA trial, and most of the patients enrolled in PARMA trial has chemo-responsive disease at the time of transplant. So, and the long-term LFS about 50% was those in the chemo-responsive patients. So, we cannot, we cannot go by that analogy to all our patients. Probably double hit lymphoma patients with, high RIPI at the time of relapse, because their long-term survival, if you see the segregation of survival based on the risk prognostication at the time of relapse, the long-term survival of the patients who have high risk IPI at relapse is just 15%.
Exactly.
So at least CAR-T, you have a 40% long-term survival. So this is the current landscape. So most important, I found this is the trends in US for autologous transplant. The upper curve shows there has been a dip, but that dip is not steeply continuing down. Still, there are about 1100, 1200 patients undergoing autologous transplant as per the CIBMTR 2021 data. And you can see the CAR-T numbers are shooting up 3500 for entire non-Hodgkin's lymphoma subgroup. And this, as a transplanter, this is a recent the CIBMTR data. I'm sorry for the poor image, but what is most interesting to note here is, like other cellular therapy platforms, novel therapeutics, transplant is also getting better and better year by year. You can see 2000 to 2018, there has been 15% improvement in the long-term survival. So as a transplanters, the outcomes in the transplant arm are also improving. And this is I took from one of the talks on CAR-T cell therapy. So even though we don't have access, but this is what post CAR-T cell therapy management is also concerned, CRS and ICANS, the CNS toxicity and cytokine release syndrome, and most important B-cell aplasia in a country like India where with tropical climate and so much of opportunistic infections, these patients will be difficult to manage here as we see even post-transplant. So the cost of management post CAR-T cell, even though the cost of CAR-T cell therapy in India might be 20 lakhs, 30 lakhs, but the post CAR-T management probably might add cost, which is a little different from what we do with autologous transplant. Once the patient has engrafted, most of the times, 90% of the times, patients continue to do well, barring relapses. The management is not that. So these all factors need to be taken into consideration. Again, durable remissions, not like what was shown initially, the hype, but the long-term remissions are not hugely promising, 40%. So many of them do lose. There are various ways of losing the response. So probably this needs to be taken into consideration. So with that, I conclude my panel discussion, and then I will like to ask Dr. Sikander sir, what is his take on based on the the CAR-T immunotherapy, cellular therapy utilization in the DLBCL spectrum. What you think? What is your perspective on the future of CAR-T in DLBCL? Is it going to come up front right at the first relapse, and what are the ways to improvise the CAR T outcomes? The outcome, long-term outcome, still 40%. What do you think?
Sure. So excellent case, and thanks a lot for that very good kind of follow-up and a capsule of information. I think there are a couple of things I want to add to what's been mentioned before, and let's take that same patient who's post-auto progression. I think at that point when the discussion comes, and Dr. Pawan mentioned about CAR T for that high-risk early relapser patient, etc., I think another very important consideration comes is, if CAR T is an option, another advantage that CARs bring with them is the long-term treatment-free interval, which, and I'm not comparing to auto, I'm let's say comparing to Pola-BR or Tafa and lenalidomide or something, because that is ongoing, continuous therapy, adverse events, visits, time away from work, time away from family, etc., etc., etc. So I think that's another very important piece. I think we did our first CAR T cell treatment about 5 or 6 years ago, and luckily at least 5 years ago. That particular patient is still disease-free, and she's a diffuse large B-cell patient we treated. In fact, she was going to proceed to hospice. The drug had just been approved, Yescarta had just been approved, and she got that. It did take she took a huge hit financially, that I get, because that was the first case. We didn't even know how to bill, insurance didn't know how to reimburse. It was a pretty messy situation. But 5.5 years later, that patient has disease-free, she's disease-free. So those success stories do happen, and that's where I would say that treatment-free interval, a term which used to be used for myeloma once upon a time, the twist analysis, time without something, side effects and treatment. I think for CAR, that's also an important consideration. But you rightly said, in diffuse large B-cell lymphoma, the number of CAR T-cell treatment is nowhere close to what we would have anticipated when these agents were approved. There are 3 agents approved. We still don't do that much. In myeloma, that number is not picking up because there are no manufacturing slots. At a size of a center, we are doing about close to 200 transplants a year, total, all of the transplants and cell therapies put together. I get 2 slots of CAR T for myeloma every month. That's nothing. We have long waiting lists. So hopefully when these logistics and supply chain issues, which in today's day and age, everything is a supply chain issue, when that happens to clear up, I think CAR T will come in sooner. For diffuse large B-cell lymphoma, we are all expecting second line indication will show up, even for that matter for follicular lymphoma. And I think another piece that we were just mentioning was to look at the quality of those T cells when they are collected. The more alkylator-based therapy and long therapy that the patients keep getting, what is the quality of those T cells that are being taken to manufacture the CARs, and are those T cells more likely to get exhausted sooner? Hence the thought that we need to keep bringing them sooner in the paradigm. Hopefully at least starting with these high-risk patients, and if we show the benefit there, then we can understand, do standard risk patients have that benefit or not?
So Dr. Pawan and Dr. Arif, your take-home message for CAR T in this in DLBCL subset?
I think it's gonna take over in no time. Probably, I personally feel CAR T should come more front because of probably manufacturing issues. We had one of our center, the primary center in country, the Tata Memorial Hospital, which has started the CAR T thing, and we had sent 2 of our patients. And most of the patients already had 4 or 5 lines of treatment, and unfortunately because of that they couldn't manufacture the good amount of T cells. So probably that issue can be solved if the line, third line, second line, it should become a second line, probably a first line like Zuma 12 in upfront very high risk patients. So I think that should become it should pick up and probably take away most of the chemo drugs. I think it will be immunotherapy based treatment than chemotherapy based.
Yeah, so it creates the immunological memory, and it's like a prolonged action. So that is very attractive, and if you give it once or twice, and it maintains a response for years, that is very attractive, and it should be the next second line and maybe front line also.
Sir, your experience about the cost of post-CAR T management, because that's where our patients need to focus on.
Sure. So actually, I will point out when I was presenting, I think the discussion point that must have come up was the $500,000 of the cost, because I could see some discussions happening right after I mentioned that. We all think this is not sustainable. We don't know what the solution to this would be. Costs are not going to come down. The subsequent approvals are coming very at the similar prices. And then very frequently we are asked, how do you prefer this versus that versus that? Well, clearly cost is not the issue, because everybody charges the same amount. I think we are picking the cars based on what we are comfortable with. If I'm more comfortable with Yescarta, or I will use that more frequently. Post-CAR treatment cost, I think, has relatively come down, because in today's day and age, we have a much, much better handle on post-CAR management. As I mentioned, we're not just trigger happy, we are giving TOCI much more frequently, but that is mitigating those bad CRSs and ICU stays and stuff. Neurotoxicity, we are triggering the dexamethasone sooner, because there is data emerging that these do not hamper our CARs as much as we used to think. I absolutely appreciate your thought about hypogammaglobulinemia. That is something we didn't touch upon today, but that is a very important thing. And in fact, our guideline is that we have to maintain the IgG level above 400. And so anybody who drifts down, they start getting monthly IVIG treatment. They will get monthly for a few months, and then we will only pick and choose whenever we need to give it. But that is extremely important. So as long as the patients recover their neutrophils, they are given the IVIG as and when needed. Long-term infections, etc., not too much of an issue. So with all of that, I think today the morbidity, mortality, and the cost of post-CAR management has significantly improved. And what I can say is that when, let's say, hypothetically, this becomes available here, we should brace ourselves that we will have some challenges in the first few cases. That is bound to happen. That's where I think utilizing kind of our connections, interactions, so the first patient that we gave the CAR T to, that lady who's now 5.5 years out, I remember it was almost 6 of us hematologists standing in that room when the CARs were getting infused, as if, I don't know what would happen. But everybody wanted to gain the experience, nobody knew what would happen. So it was a very steep learning curve. But now we don't even think twice about it. It's a very standard process. It's a revolving door. We have a process set up. So I think that is where we are around to help set up the processes, set up the SOPs, try to figure out how to do things as standardized as possible. There will be a steep learning curve. There will be an initial increased cost, but I'm quite sure it will come down with time. One non-CAR thing that I wanted to kind of touch upon was asking for your thoughts around that same case that you had. We talked about the molecular signature at the time of diagnosis. Is there a role and is there practice to, for example, when that patient progressed, to consider doing NGS on a repeat biopsy, or even going back and taking the original tissue and doing that repeat the NGS to potentially look for PD-L1, to look for other things? Is that frequently done? Because I'm also of the mind, or I understand that the cost of doing that kind of a panel, or those even large panel, 500, 800 gene panels over here, is a fraction of what it is in the US.
Yes.
So are we doing that routinely?
So this case we did PD-1 at relapse, just exploring the options which we could use in this case. So again, the PD-1 on ISC is hardly $15,000. NGS per lymphoid panel is about 45,000.
30.
So it's not as high as it is at your place,
Yeah.
but yes, that was the point I was mentioning it's worthwhile to start looking at
Yes.
our subset of patients and see. At this point of time, not all of us do NGS, but yes, IHC for such high risk cases, those who have a high RPI, RIPI, or those who have stage 4, stage 3B, large tumor metabolic mass patients, we do on ISC P53, TP53, and CMIC on fish. That's a common practice, but barring that, NGS as elsewhere in the world is not a practice.
So one thing that we've started doing recently, and I'm not the biggest fan of Foundation One and Tempus and all of that, because actionable mutations are not found, and you're spending $7,000-8,000 doing a test which may not get reimbursed. It's very costly for the patient. So we were not doing that, but there is a different platform we have started using a little bit more frequently now. And when I say little bit more frequently, going from 0 cases to maybe 5 in a year. So more use. It's a different platform, something by a company called Boston Gene that was a spin-off from MD Anderson. And what we found very helpful is their report is way more comprehensive. They don't just give a 400 gene panel. They will talk about tumor microenvironment. They will talk about the T cell repertoire. The report comes, they will give genomics, they will talk about proteomics. Now you can say that yes, it may not yield much benefits at a 10-page report, which is for academic interest. But in one case, we actually suggested that the patient, so this was a test case that they had presented to us, and that's what at least changed my mind about it. That was a diffuse large B cell, progressed, multiple line, etc. CAR T, soon after, 6 months after CAR T progressed. Think of it this way, that $500,000 we talked about literally went down the drain because it didn't yield much. And then they found PD-L1, and they gave the patient one of the PD-L1 checkpoint inhibitors, and the patient did much better for a long period of time. But when they were showing that report, we actually picked up something on the presentation and said, well, there is a Treg fraction, a regulatory T cell fraction, and that was significantly downregulated in the pre-CAR sample, because they ran the testing on the pre-CAR sample that was available. So the question became, as we are using these biomarkers, should we be considering a T cell related biomarker, whether it is the Treg level or tumor immune microenvironment, to help suggest who may actually benefit from this extremely costly and intensive treatment? And I think that if we are able to get to that kind of a smarts, I think that is where the bang for our buck would be. So we've started using that panel a little bit more.
So Dr. Vamshi, we have another 5 minutes, I think. Yeah. So just it's always a great opportunity to learn from the legends. So in India, I'm sure all my eminent colleagues will agree. We have only one chance. Whether you do ATO, you allo, CAR T, only one chance. After that chance, just an example. I had a primary myelofibrosis patient. I transplanted 5.5 years back. He has poor graft function, and we have been for past 5 years trying to convince him for stem cell boost. He is still 100% donor chimerism, but he is not willing to shell out that 4-5 lakhs. He comes in once in a while, gets transfusions. All the growth factors have been tried, and that have been able to maintain his graft. So the point is, you have only one chance in India, because most of the times it is out of pocket. So under such circumstances, for particularly our subset of patients, we need to define exact group of patients where either CAR T will be the best shot, or whatever transplant will be the best shot. Again, going by the same analogy, the pediatric transplants, haplotransplants, all of us have a surge of patients for haplotransplant. So particularly XYOT deplete haplotransplant, TCR alpha beta CD19 deplete CD45 RO pushback. So the outcomes have been so promising through the literature. I had 7 patients. One patient who has no hope at all, multiply relapsed CML blast crisis. He is now 7 years post T deplete transplant. You can understand, adding now the cost has come down 6-7 lakhs, 7-8 lakhs for T cell depletion. Most of the patients, even the affordable patients, don't opt given the choice. So under these circumstances, probably the CAR T and the post CAR T management versus possibility of relapse post CAR T, it's a real challenge. So what is your suggestion? And there has been enough literature coming up this year and last year. This what you correctly pointed out. Irrespective of these markers, immune checkpoint inhibitor just before CAR T to upregulate these tracks and increase the chance of sustained remission. What is your suggestion?
You're absolutely right. I think whatever we can do, even post-CAR, pre-CAR, that we can have a better chance of it working. You're absolutely right. That one chance is always going to be the best. In one of the myeloma trials, which is KarMMa-3, which is their standard of care versus CAR T cell with Islet Cell, I had about maybe 22, 23 patients on that trial. That trial does not allow post-CAR maintenance. And we are so sitting on pins and needles because we know that everybody is going to progress. I have only about 3 patients who are left who have not progressed. And as a matter of fact, all 3 are 17p deletion. I don't know why, but those are the only 3 who have not progressed. Maybe because they were younger and they had healthier T cells or whatever. So we have a clinical trial going on again in myeloma. I'll dig more from the myeloma database just because that's what I do routinely, where we have CAR T followed by, they had 3 different possibilities of maintenance. One was iberdomide, which is the only arm that continued. Other 2 arms were stopped. But sometimes there are some unintended consequences because that patient who started iberdomide, so an immunomodulator, 2 months after the CAR as maintenance for T cell recruitment and sustenance of response, he went through the first cycle, which was the dose limiting toxicity period for the trial. He's clear, got the 2nd month of treatment, and he became cytopenic from the IMID. And he came in, this is a patient who had come from UK and had said that he had enough money to afford 1 CAR. By selling off everything, he will have enough money. So he said, I'll pay cash, give me CAR T cell. I said, no, I'm not going to ask you to sell everything. I'll find you a clinical trial slot and I'll give you clinical trial treatment so your CAR T will be free. And then you only have to take care of some standard of care stuff. The guy went on to the trial, got his CAR T, got a VGPR, and then started on maintenance. 2 months later, over a weekend had a fever, decided to wait for 2 days, and he ended up septic in the ICU with 5 pressors. And so that's where the thought was that, okay, the idea of using a maintenance for continued T cell engagement can have some unintended consequences. Luckily, that guy came out of the ICU and he recovered, etc., etc. But as you mentioned rightly, that whether there is no benefit, all of us in the room, we want to do whatever is best possible for the patient sitting in front of us, right? So whether you came up with ibrutinib, venetoclax, dex, no data, whatever, there is data, ibrutinib, venetoclax, and Waldenstrom. So why don't, or other lymphomas, so maybe it'll work. And it worked. So whatever we could do over here, we are able to do a little bit more of that experimentation. I guess with T cell engagement or immunotherapy, my only concern, or I'm a little leery of trying to mix and match, because I think the unintended consequences are what I'm a little concerned about, as in what could happen down the road. I am quite sure that all of that data will emerge. A lot of these CARs are actually being modified. I can tell you right now, there are more CAR T trials that are getting stopped, and the companies are throwing away those constructs and building new constructs, because what they're realizing is that they are not seeing as much incremental benefit as they had expected against the original drugs. So I would say it will happen. Those modulations will happen. Cost will come down. But this is one category of treatment where I'm a little leery that we do something ourselves without data, because there can be a lot of unintended consequences.
Thank you so much for your input, sir. And I'm sure all of us have a lot of take-home messages. So if I had to sum up, the messages from Dr. Sikander sir and my eminent panelist and the august audience of all the experts in the field. So for a country like us, probably upfront CAR T for subsets like, I had seen the CAR T trials, the enrollment is up to 92 years of age, which is none of us take them for transplant, whatever transplant after 65, 70. So elderly patients and those with this high risk IPI at relapse, early relapse, and the high risk genotype like double hit TP53, these probably are our best shots for upfront CAR T. And autologous transplant still holds promise. There has been a huge, debate and discussion after 2018 that probably autologous transplant, you see that initial dip in the number of auto transplants in relapsed DLBCL setting from the CIBFTR data set in 2018 from US. So people were thinking that autologous transplant as a consolidation is completely go away, just like has happened the transplant in CML. Now the transplant in CLL is going away, but it is not the same for us. Still, autologous transplant is the best possible consolidation approach for patients not fitting into the ultra high risk profile. Our standard autologous transplant still holds the role, and CAR T upfront for our patients who can afford only one shot, so high risk, elderly, and this genetic profile. Thank you so much. And with that, I thank the AIG team for this opportunity, and it is really a privilege and honor, sir, to be with you on this.
Thanks a lot.
Thank you.
Thank you.
Thank you all eminent panelists for a wonderful discussion.